Hello and welcome to the screencast on remediation therapy in aphasia. I'm going to use the terms remediation and restoration interchangeably. The idea here is that there is some kind of process going on that is going to try to improve the function of the individual with aphasia. And those two terms are often used pretty synonymously. So when you work in skilled nursing, the term restoration or restorative is often used. The ASHA documents tend to use the word remediation. So I'm going to use those terms interchangeably, so keep that in mind. So I want you to think about the idea of approaching a treatment program by establishing your view. And we really have three things that we can kind of do for people with aphasia. We can try to remediate, that is working to make the problem better, trying to get as much improvement as we can in function. We can try to compensate, that is not necessarily trying to make the thing better, but trying to find a way around the problem that can get the person still participating without a specific skill necessarily there. And lastly, counseling, which is to help the person to have an adjustment to the changes in their life, for them to understand their disability, etc. So those are really the three things that we can do. And I often think about this when I approach a new patient that has aphasia. I'm going to say, I use the eggs in a basket analogy. You know, the old saying, don't put all your eggs in one basket. This is how I think about the program. I look at the person. I look at where they're at in the recovery process, how far post-onset are they, what's their educational level, all of those prognostic kinds of indicators. How much therapy have they had in the past? What do we know about the progress that they've made in that therapy? And I talk with that person about what their goals are, what they want to achieve, what they're looking to do. And then I say to myself, how much of what I do should I put in the remediation basket? And how much of what I do should I put in the compensation basket? And how much of what I do with this individual needs to go into counseling and education? So if I have 12 eggs, I have a dozen eggs, I might in one case say, I'm going to go 5 eggs in remediation, 5 eggs in compensation, and 2 eggs in counseling and education. Because this is a person who's not very far post-onset. They've been through inpatient rehabilitation, but they've only had maybe 6 weeks or 8 weeks of that. They really want their skills to improve. That's where they're focused. But they have some areas where they want to start participating again, where I have some ideas around how I can get them participating, even if their speech is not, speech and language skills are not completely restored. And they've had a lot of education. They seem to know quite a bit about what it is that they're encountering, but there are still some areas where continued education and continued supports may help them. So that's how I would make that decision. And I literally think of it in that way, to help me to have a framework around how will I write my objectives, what will my objectives be written around, where will my emphasis be, and how will I approach this treatment. One of the key factors that you want to consider, however, when you're doing this is not totally your decision. Evidence-based practice is external evidence, which is the extant literature. Internal evidence, that is what is happening in this therapeutic room between me and this person. What is my clinical evidence of what is happening? And that is driven in part by data. Not just your feelings, not just what you believe, but what does the data show happens with this individual with the application of certain techniques. And lastly then, the idea of the patient's input into the process. We have to know what it is that the patient desires the outcome to be. What does the patient need to do? How do you know that? Interview, 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 interview. Interviewing is so key and integral to what happens to try to form this plan. You want to include caregivers if they are available. You want to include the patient, absolutely. But that is a key component to evidence-based practice. And without that patient input about what they want, you are not engaged in evidence-based practice. Evidence-based practice is not just about the extant literature. It's not just about journal articles and patient portals. It is also about what happens in that room with that patient and what that patient needs and wants to do. So here's some Weisling biases for you. Trial and error is not therapy. Trial and error is a technique that I see happening. Drill and practice is not therapy. I know that some sources say, you know, they use the word drill and practice, but I think it's more than just drill and practice. It is practice with the application of knowledge and clinical decision making about when to practice, what to practice, when not to practice, when to practice more, when to stop practice. And that is more than drill and practice. So I don't use those words, drill and practice. And remember, don't do trial and error therapy. I think it can be harmful to people. If practicing can improve a function, then practicing can make a function worse. Because if you practice how not to do a skill, you can actually practice the wrong thing and end up with a person who has a really bad habit that you've created as the therapist. If you're doing trial and error therapy, there isn't enough of anything to cause neural organization to occur because you're just haphazardly applying things that you think of in the moment and aren't systematically evaluating. So when would we do remediation? Remediation would be attempted when the client isn't very far post-onset and the prognosis for recovery is good, and we want to try to springboard off of spontaneous recovery or the spontaneous regeneration of neural networks. It is attempted when the client isn't satisfied with the compensations that we've put in place and they want to improve the skill. Again, patient input. We use remediation when there is not a life-threatening issue attached to a skill. For example, I would never want to have a person who needed to be able to request their medications in a facility in order for them to be able to participate at that facility, not get their medication because I'm still trying to remediate their ability to ask for the medications they need. Instead, I would put a compensation in place, right, so that they can get the meds that they need. And I could work on remediation maybe as well, but my primary there is to get the need met, which kind of feeds into that basic communication skills have been established. The very first thing that you should be doing with an individual with aphasia is establishing basic communication skills. You should not be remediating, waiting for them to get basic communication skills in place once you've fixed the problem 3 months from now. They need a way today to tell people they love them, to tell people what they want and desire, to tell people, to give people information about what is happening to them and how they feel about it. That needs to be in place day one. Day one. Not 3 months from now after you've remediated them. Today. How are you going to put things in place for them to meet their communication needs today? Once that's in place, you can go back and say, okay, now let's try to work on, let's get these skills back online. But we have to keep them in the communication game. So there's a treatment approach out there called constraint-induced language therapy where people are not allowed to use compensations. They have to use their speech to communicate, because the idea is that if you don't use a skill like your left arm because you have paralysis, that you'll learn not to use it, right? You'll learn non-use. And so they apply that to language. If you don't use language, you'll learn non-use and you won't use language. Well, I would argue that by having the person not able to communicate through their language system and not allowing them to communicate, they are learned non-use of communication. In other words, I don't have to communicate. I can be an actor in this hospital room. I can sit in this hospital room and people will bring me what I need. People will tell me what's going to happen next. People will make decisions for me. People will interpret how I feel, and I don't need to communicate because I'm just waiting for the magic bullet that gets me my language. So I think that we have to think very carefully, theoretically, about what learned non-use means. And so my bias is that we need to get people communicating, and we need to get them communicating early. So we are going to remediate after we have in place some basic communication skills to keep this person in the communication game. So if we think about remediation, there are three basic types. There's stimulation facilitation, which is also called Schul's stimulation approach, which I'm going to talk about. Didactic, which is the reteaching of skills. So this is a noun, this is a verb. Nouns and verbs go together in this way. The way we teach children, right? Where's the noun in the sentence? Find the noun, find the object, of the preposition. That kind of teaching, okay, which does not have a lot of really substantial evidence for generalization. It's actually not a recommended practice, but we do see that there are programs out there that look a little didactic, but the idea of verbally trying to teach someone language is not a well-accepted way of approaching aphasia, but is sometimes a way that I see get observed as an approach. Not well-founded, but I want to mention it so that you know what it is and can recognize it and not engage in it. And then lastly, what I call canned approaches. Now these are approaches that are programmed approaches. So I call them canned because, my mother used to say there are two kinds of soup. There's homemade soup and there's canned soup. It comes in a can. All you do is add water and put it on the stove and you have soup, right? It's canned. It's all right there. It's every ingredient you need packaged together. And that's what I mean by canned approaches. So these are programs like melodic intonation therapy, the treatment of Wernicke's aphasia, script training. There's very prescriptive ways that you are going to approach the therapeutic interaction. It's all laid out for you. You don't have to do much interpreting. So I want to talk about stimulation approach or facilitation approach, also called Schul's stimulation approach. The efficacy data in this is inconsistent, but I think that the efficacy data here really is affected by the fact that not a lot of people really understand what Schul said stimulation approach should be. It was taken, when we talked about critical thinking and we talked about simplifying thinking, there's a lot of simplified thinking that goes into stimulation approach. There are a lot of people who believe that stimulation approach is any stimulation you give to a person. That's not what it is. It's not what Schul and colleagues talked about. So I'm going to take you back to the original literature. I'm a bit of a Schulian stimulation approach fan, not in that I think that it's the only approach or the approach that should be used all the time, but that when it is appropriate and it is done well, I've seen some good results with it, and there are many approaches that actually tap into the principles of stimulation approach. Many of the canned approaches tap into the principles of stimulation approach. And so I think that sometimes the efficacy data is affected by, as I read the studies and their procedures, I'm like, well, that actually violates one of Schul's principles of stimulation approach. So I want you to understand what it is so that if you're going to apply it, you understand what it is. So the next few slides are a combination of information from the Schul book, Schul books, and my clinical practice, and some of the more modern ideas about what does it mean to practice and that kind of thing. So Schul's stimulation approach, Duffy describes it as an approach to treatment which employs strong and controlled and intensive auditory stimulation. And when you think intensive, I kind of almost in my head think about practice, right? There's a lot of active engagement. It's intensive. It's controlled. It isn't random. You don't pick the next item that you present to the patient because it's the next card in the stack that you have in front of you. You pick it because of the response that you got from the patient on the previous item, and you carefully control what happens next. And it's strong in that the stimuli that you present should be at the patient's level such that you elicit from them the response that you want. So that she talks a lot about the adequacy of the stimuli. The stimuli can't be too hard or too easy for the patient. It has to be just at the right level to get the person to respond to it. And the auditory modality is often talked about as the key factor. Schul actually believed that the auditory modality was the modality that helped drive language development and language itself, because we hear words that are spoken, and that's how we begin to develop this language system, and then we use our vocal tract to emulate what we've heard. So she really believed that the auditory system was important. So I'm going to take from page 338, I'm going to take some snippets for you to kind of digest. She said that it would seem that sensory stimulation is the only method we have for making complex events happen in the brain. So what she's saying is, if you want to try to get a part of the brain working, right, you have to provide some kind of external stimuli to it. It's a pretty simple principle, right? But she wrote it down. She's saying you have to do something, you have to do a task, you have to do something with the person in order to get the brain to activate. And then she said, in our opinion, the clinician's role is not that of a teacher, which is why I would never use the word teach to describe aphasia therapy. We're not teachers, she says. He has nothing to do with teaching the adult aphasic. Now note, she used the word aphasic, but remember this is 1960. We don't use that term anymore. We would say person with aphasia today. To talk or read or write. We're not teaching them to read or write. That would be a didactic approach, which we wouldn't use. He does not teach the patient sounds or words or rules for combining them. That's what she says stimulation approach is. She says rather, he tries to communicate with the patient and to stimulate the processes to function maximally. So you're presenting stimuli to this person that you think they can respond to. Oh, are you telling me that last night you went to your friend's house, or your friend came and visited you, and you sat in your, and the patient would say chair, maybe. Right? So the idea that you are trying to provide stimuli to this person that's going to allow them to do a skill. She also says that this suggests that the first principle of treatment for aphasia should be the use of intensive auditory stimulation, although not necessarily through auditory channels alone. So in other words, there's also visuals provided. We've mentioned before that patients who could neither repeat nor read a word responded correctly when they looked at the word while it was spoken by the examiner. So this idea of dual sensory input, both visual and auditory input at the same time. Subsequently, either stimulus could evoke the correct response. From a series of studies, they concluded that the influence of one stimuli on the other seemed to be a fundamental principle. So the idea that this multimodal stimulation, vision and auditory, in patients that have pretty significant aphasia can be helpful. And then you would fade the visual support if what you were going for was that the person could just read the word or say the word aloud. You might take away the visual word, but it might start with them having the visual word and having the clinician say the word. So in aphasia, combined auditory and visual stimulation is effective in eliciting language on progressive levels of complexity. It should be continued until the patient can respond to each modality alone. So they could repeat the word after the clinician and they could say the word that they saw written, right? So you're trying to move towards taking two modalities, vision and auditory, and separating them out so they can respond to the vision or the auditory stimuli. And the skills become functional if the procedure is followed. And this is a really key thing that Schul said about interacting with people with aphasia. People talk too fast and say too much at a time for the aphasic patient to follow. Patients sometimes tell you that people do not seem to be talking right. And to some patients, it often seems that they're not even talking in a language that he or she knows. Therefore, the clinician must manipulate the stimulus so that the patient can perceive it. Using a combined auditory and visual stimulation is one way to do this. As soon as the patient can respond without such assistance, either stimuli can be used alone. The object is always to enable the patient to communicate as normally as possible. Okay, so a lot of people will say, well, stimulation approach, that's very impairment based. It's very focused. Schul actually talked about how all of this needs to be about what the patient can do functionally, so that whatever stimuli you're presenting needs to move quickly into functional activity. So here are some principles of stimulation approach that I've identified for you to think about. They might apply to many different kinds of therapy that we do, but they absolutely apply to stimulation approach. First is that we use some kind of practice. Schul called it repetition, but I don't want that to get confused with the idea of repeating, like I say something, you say it back to me, right? So in the older literature, the term repetition was used as a way of talking about practice. So people need practice at a skill. If we're going to have an impact on learning, there needs to be practice. There are two kinds of practice. Mass practice, that's where you do a thing over and over and over again. So let's say that I'm going to do just a classic naming task. I'm going to show the person a picture of car keys, and I'm going to say, this is a set of. Okay, now I've given right there, I've given a stimulus prompt. I've given kind of a very weak closed procedure or semantic cue, but it's pretty weak. A set of, it could be a set of dishes, it could be a set of salt, pepper shakers, or it could be a set of keys, right? So it's not as strong as you unlock your door with keys, right? Because there's only a narrow answer to that. So I might present that and the person might say keys, and then I might say good. Say it again. Keys. Again, keys. Again, keys. Again, keys. So we have mass practice. Then we have the second kind of practice, which is distributed practice. So once I've done that mass practice, which we do when a skill is emerging, when we're starting, when a person is having a difficult time mastering a thing, we do mass practice. Then I might go to the next item in my stack, and since we got keys, I might look in my stack and see that the next stimuli is car, and I might think to myself, car might interfere with keys because car keys, and they both start with the phoneme k. So I skip car, and I'm going to go, the next in my stack is cup, and I go, oh, still got the phoneme interference, k, keys and cup. So I skip to the next item in my stack of cards, and I see that I have a shoe, and I say, okay, I'm going to do shoe. Okay, because keys is not related to shoe semantically, and phonemically it's different. I'm going to show the picture and say, oh, here I have a, and the person might say sheet, and I might say, you tie your, and they say shoe. Okay, so I've done a correction procedure. I've tried to give them a more specific close. They said shoe. Now I might say good. Say it again, shoe, again, shoe, again, shoe, good. Now I'm going to go back to key. So I have mass practice shoe, and I am distributing the practice on key. I bring key back and I said, you said this was a set of, and they say keys. Okay, now I've distributed the practice. Okay, that's what I mean by it's not drill and practice. Do you see A, how I manipulated the stimulus? B, how I employed mass practice at times and distributed practice at other times. Those are important elements to what happens in a good stimulation approach. And I was very careful how I selected the stimuli. We want a low error rate. So once an error is made, we want to try to prevent an error. We want to try to get the person to have the stimuli be adequate, that they will produce what we want them to produce, and then we'll talk a little bit about fading back the support. But we want to start there so that they get the correct response. If they don't, we want an error correction procedure or a consequence that is likely to get them to produce the correct answer on the next item. That might be a model. I might say shoe, it's a shoe. Say shoe. Right? Instead, I decided to use a more specific close with you tie your shoe, because if I know this patient, I might know that they do pretty well with those. Okay, so again, it's patient by patient. It's day by day. Today they're responding well to it. Yesterday they didn't. Tomorrow they might not, but right now they are. So I'm going to use it. I'm going to try it. I'm going to risk it. So it is constant decision making that is occurring. So we want to keep our error rates low. Errorless learning means that you're in a procedure where no errors can be made. Most therapy is not completely errorless, but often we do want to try to keep errors low. Now, Schul said this not by talking about error rate, but by saying that you should never be working on something with a patient that they can't do with at least 60 to 80% accuracy. That's the starting point. So if you have a task that you have this person doing, they should be responding to you correctly 60 to 80% of the time at baseline. So as you think about setting criterions for objectives, it's very important that you not select a task that the person can do with less than 60% accuracy, because you are actually working to reinforce their error production if you do that. So we want to try to keep these errors low. Next, we're going to decrease, or difficulty is slowly increased. We're going to slowly increase the length of the things that we ask them to do, moving from word to sentence to connected sentence, for example, and the complexity. I talked a little bit in my example about not putting key by car, because there's a semantic interference of car key, and there's a phonemic interference of ka and ka, right, in the production of those words. So those kinds of complexities that occur because of semantic elements, syntactic elements, the meaningfulness of what you're talking about, or the saliency or the phonemic complexity of what you're asking the person to do. Saying the word television is more phonemically complex than TV. So selecting what your stimuli is going to be on a level that the patient can handle. If you're trying to move them up, you might select television. If they're not doing as well, you might select TV, because it's less phonemically complex to code. Lastly, cues are used to increase the accuracy of the patient. The cues are used as a consequential strategy, and they are faded. And you're going to fade them as you integrate practice and into the activity. So the cues are going to lessen with each practice. You're going to give less information to the patient for each practice as you try to fade away the cues through increasing the amount of time since the last cue was given, and by decreasing the or increasing the interference. So I'm going to give you an example. I'm going to go back to my shoe example. I give the patient a picture of the shoe and I say, you tie a, and they say shoe. I've just given a pretty intensive cue. The intensive cue was you tie a. There aren't too many answers to that other than shoe. So it's that semantic cue is very highly interactive with the word shoe. So now I say, good, say it again. Say it again is not very semantically interactive with the word shoe. But it is quite a few words to decode, and the person might not be able to handle that. So if I say it again, and they can't say shoe, they might say again, because the last thing they've heard is me say it again. I might go back and I might abandon that item and go to a different item, and start the whole process over. But if I were going to stick with it, which I might or might not choose to do, again, clinical decision making as part of treatment, I might say, this is a shoe. Say shoe. Now I've said say. That's all I've said since shoe. The person says shoe. I might say good again. Now all I've said since the last thing they've heard is say and again. They say shoe. Now I might say great, you're starting to get it. Now I've put a sentence in since the last cue. They say shoe. I point to them, they say shoe. I say you're doing really good. We've talked a lot about this. You called it a, and now shoe. So it's less predictable. We've talked a lot about this is less predictable than you're really getting it, right? So I am increasing the amount of interference since the last time the person heard the word they're going to say or produced the word that they're going to say. So you're intermingling that into your practice, right? So they're practicing, but you're intermingling these little things that you're doing that serve as interference. And when you do that, there has been more time and more interference since the cue that elicited the response was given, which was you tie a shoe. Okay, you may need to listen to that segment of this a couple of times to get it, so feel free to keep using this talk. So we talked about this principle that Schul said tasks where 60 to 80% of responses are correct are good starting points, and that is that no more than 20 to 40% of responses should be an error. Okay, so if you baseline and you want to work on following one-step commands and you baseline and they can only do that 50%, you need to back up. That's too hard. Maybe you need to go back to single word pointing, or maybe just doing some not full commands but almost half commands, right? Like touch key, point to key, right? Like it starts to back away from a bigger, longer command. So you want to be targeting things that fall between 60 and 80%, which means your criterion needs to be set higher than the baseline in a way that is meaningful. And so go back to that PowerPoint on setting criterions to help you for objectives. Talked briefly about canned approaches. The strengths are that those approaches that kind of come prepackaged, like melodic intonation therapy, sentence production program for aphasia, things like that, give a clinician direction. They're good starting points for new clinicians who are less experienced and might not be able to manipulate all these variables that occur in a stimulation approach. Some of them have some good efficacy around improving impairment. Sometimes they don't always generalize to activity and participation. It's sometimes easier to obtain efficacy data on these because all the procedures are laid out step by step, and so we know that everybody's following the same procedures, wherein what I described in stimulation approach is quite dependent on the clinician's particular decision-making skills, and often the materials are provided. So those are good things about canned approaches. Some of the weaknesses is that patients may find them boring. I've used melodic intonation therapy and some of the other therapies like sentence production program and aphasia, and some patients tolerate them very well and like them. They like the structure. Others feel like it's just too, it's too structured, and they can't expand and explore the way they'd like to. The rules can be very cumbersome for clinicians to follow, and if you don't follow the rules, you may lose the validity of the treatment approach. You can't just drop things out of the treatment approach if you don't understand why they're there. You can't just willy-nilly get rid of things and say, oh, I don't understand what that is, I'm not going to do it, because you may actually remove the part of the treatment approach that makes the treatment approach work, so you have to be very, very careful. Some of them might not be founded on a good model or principle of therapy. Some of them may be, and they may not account for cultural diversity. They may, since the stimuli are prepackaged, right, you may be using stimuli that people of a certain culture would never say or do or recognize, and so you have to be careful to be sensitive to that, and maybe have to substitute in some culturally sensitive kinds of activities or remove some things that are not appropriate for a particular person's culture. So that's what I have for you on remediation, and I'm sorry, or on remediation approaches in aphasia. I'm sorry that this is a longer webcast, but there's kind of a lot to cover, and I wanted to try to get at some of the basic principles for you. I hope that you'll find this helpful, and I hope that you will think carefully about what the therapeutic intervention that is restorative really looks like in people with aphasia. Thank you for your time.